Okay, so the objectives for this talk is to just review the causes of non-responsive therapies in general, to review a little bit about the background as it relates to thiopurine drug monitoring, since that's actually kind of our old school reference for why we do therapeutic drug monitoring. And the crazy thing is a decade later, it's kind of the same concept of, low drug levels gives you lower efficacy, higher drug levels may be associated with higher safety risks. So it's kind of interesting to come full circle in that regard. Also talk about, obviously, focus then on therapeutic drug monitoring as it relates to anti-TNF therapy. And after DDW, there's going to be an explosion of the next phase of therapeutic drug monitoring, which is Adalimumab levels actually will be available to us. So stay tuned for that update. Probably next time you hear this talk, there'll be a whole bunch on Adalimumab monitoring. We'll talk a little bit about the impact of immunogenicity and really kind of how the future of biologic use will look, and kind of start for you to think already now maybe how you may be able to change your practice with the tools we actually have, because I think you could really change the natural history of outcomes on anti-TNF therapy if you think about how to use these drug levels at the right time and in the right patient. I'll kind of walk you through some of that. So just in general, to remind everybody that the potential causes of drug response potential causes of why people respond differently to these drugs, and the heterogeneity of how you give you can have 20 people, you give them all the same dose, and they would all respond differently. They'd all have different drug levels, and they'd all have different safety profiles. And I think one of the things that's definitely inherent is obviously, the fact that, can we go back on this? That's fine. The difference is really the inherited differences in metabolism and disposition. So I think the fact that if we recognize that there's so many genetic variants in the way people metabolize these therapies, and that the differences are probably inherent to an individual and not necessarily transportable to all patients. And I think that's why I go back to thiopurines, because that's what we really learned about thiopurines, is that at the end of the day, the actual dose that a patient will need to induce and maintain remission with thiopurines remains completely unknown. We have no predictors of what dose that specific patient's actually going to need. So hopefully further work is going to be able to actually start modeling that and using PK profiles of thiopurines, learning what we're learning from anti-TNF therapies. So just to remind everybody that the idea that there was a therapeutic drug level with thiopurines dated back to already almost 13, actually more than 13 years ago that the research started, but was published almost 13 years ago, the idea that there was a notion you can try and achieve a level in a patient who wasn't responding, and you wanted to look for a reason why, and you felt that it was probably due to the fact we weren't just giving them enough drug. The theory was if you take a patient, measure their drug level, if it was below what we consider to be therapeutic, you should dose escalate and try and achieve a therapeutic level. It wasn't suggesting that a patient who's doing well, who has a low level, that you should dose escalate. That wasn't actually the theory then, and a lot of people challenged the idea of, should I be testing it on everybody, and if a patient is doing well, should I dose escalate them and try and get this therapeutic range? What's interesting, we would often say no. But now what's interesting with TNF levels, we're actually saying you should, if you have a low drug level, even proactively try to get therapeutic next time and maybe dose escalate and keep a level therapeutic, and don't let a patient ever get a low level because they'll flare. We never had that thought process with thiopurines, which I find interesting. And no one really has taken a patient and randomize them to say, I'm going to escalate you versus I'm not going to escalate you, really, and see whether or not the long-term remission is altered if you would take a patient where you didn't ever escalate them to try and achieve therapeutic versus those people you did escalate. We tried to do that with the NIH, but unfortunately, we weren't able to get enough people enrolled. Why? Because every human has seen the drug or has had already on a biologic by the time we got ourselves organized with the study. So unfortunately, we weren't able to enroll because that's what we wanted to do. The FDA, the NIH would like to know, and our payers would love to know whether or not we should blindly just be dose escalating patients even if they're doing well and they have a low level. So instead, hopefully we'll be able to do that with TNF. So that'll be our next, the future. But the idea is that if you can take a patient who has a low level, aka known as less than 235 for the purpose of this paper that has remained ingrained in people's heads, 230, 235. The theory was you can take a patient who is below 235, and if you escalate them to above 235, you'd have a 5-fold increased likelihood of a patient being in remission. That's pretty good, 5-fold odds ratio to get a patient who wasn't well into remission by dose escalating them. Following to that paper, there was a meta-analysis published by the group out in Philadelphia that said, indeed, if you can get a patient above 235, it's not quite as great as 5 per the Dubinsky paper, but it's closer to around 3.27. If you take all the papers into consideration, who kind of looked at the ability to say, is there a cut point, a therapeutic minimum I need to get my patient to increase the likelihood that they'll be in remission, ended up that your patient would be 3-fold increased rate of remission if you get them from a below 235 to above 235. Remember, this was never a randomized study. This wasn't where we intentionally dose escalated people to get to 235 versus not, so I want you to think about that. But at the end of the day, here we are, almost more than a decade later, and we're still saying the exact same thing. So when things start to stick true, I would tell you that every paper since the even meta has suggested that higher levels of thiopurines correlate with better efficacy. So what are the lessons that we learned? We learned why levels in general, meaning drug levels, again, I'm not here to necessarily push the idea of thiopurine monitoring at the moment. It's really more about TNF monitoring, but this is about lessons learned, and the lessons learned is that non-response, one of the main reasons for non-response in therapies we're using in IBD is low drug levels. So I think you can take that with you when we go now to talk about, we talk about anti-TNF therapy. So why is anti-TNF therapy monitoring useful? Well, there's a number of reasons. One, there's a lot of patients who are currently on anti-TNF therapies, and since 1998, can you believe we're just starting to figure out how to use that? So that's kind of crazy when you think about how long we've had these therapies, and we're just trying to figure out why some people fail and why some people don't, and what do we do with loss of responders, and how much of a role is immunogenicity in this drug really, and should we be dose escalating just based on level, and who cares if our patient has any symptoms? So we're just kind of actually starting to learn it, which is actually really cool for those of us interested in therapeutic drug monitoring because it gives us a lot of questions to answer. So I think one of the main things is that monitoring strategies can really help identify patients who don't have enough drug, patients who have enough drug but are just really active and this drug isn't really the right drug for them, and or the patient who's developed immunogenicity, meaning antibodies against the drug, as a reason for why they're no longer responding. These aren't the patients that are getting bad infusion reactions. These aren't the patients that are getting severe injection site reactions, anything that are lupus-like or delayed hypersensitivity. These are purely patients who at one point were doing well and are no longer doing well. How do we explain it? Who are these people? And I can tell you at the end of the day, drug levels probably give you most of that answer. So it's kind of interesting that we're beginning to learn a lot about just measuring drug levels. And any questions regarding reimbursement, please reserve for another time other than today. Today it's only going to be about science. So if you want to ask me outside the room about how do I get these things paid for, I can give a whole probably 2-hour lecture on it. So just meet me outside. But that's not the purpose. The purpose today is really to talk about, in the ideal world, pretend it was free and pretend everyone got it. How should we be using it? Because someday I assume it will be paid for by the payer. So, more than even now. I will tell you that payers are going to realize that this is probably the most cost-effective thing they can ever pay for, is to actually let us get a drug level in real time, maybe even at every infusion. So let's talk further as I progress you through the process of where this data comes from. So the data actually started 2006, where the idea or the notion that there are patients who do better on this drug versus other. And the group, Elena Mazur, when she was in Toronto, she's now at Mount Sinai in New York, when she was doing some work in IBD, Gord Greenberg, who really is very interested in therapeutic drug monitoring, said, let's take all these patients that we have CRPs, we have endoscopic evaluation, we have clinical evaluation, and let's look at the drug level that they have at the time of their infusion and see, let's say I took everybody in this room today, a cross-sectional, and we have data on all these people, what did their drug level look like? And at the end of the day, it looked like drug levels, the higher the trough level, meaning the drug level at the time of their infusion, the higher that drug level, the lower the CRP, the better the endoscopic remission, and the better the disease activity, meaning more durable remission, patients staying in this 8-week remission phase. So it looked like people who had drug detectable at the time of their infusion did better. Makes sense, great concept, similar to the thiopurine concept that if you have good drug levels, you should do better. Okay, so then we looked at it in the context of also, okay, this is interesting. So when drug levels first came out, there was a lot of discussion and concern, a lot of it from industry, that they were concerned that drug levels were somehow going to make people make the wrong decisions or move people off of drug, not really understanding how critical these levels are at keeping people on drug. It was a complete 180 from what you thought drug levels and monitoring was going to do, because the concern was, oh my God, everyone gets antibodies and I'm going to be switching from one to another. At the end of the day, the number one reason why people are failing the drug they're on is low drug level, not immunogenicity, and not even disease that's unresponsive. So if you had a pie chart, the number one reason is low drug level. So what these do is these actually tell you that patients are in more sustained durable remission if people have, is there a pointer? I'm sorry. No? On this? Signals. Okay, so if you look at this graph, sorry, until I get the pointer, is that if you look at the subjects with sustained response, you can see that there were more patients who had, it should be less than 3.5 versus greater than 3.5, and patients who had higher drug levels. Okay, sorry, underneath all this. Okay, patients who had higher drug levels at week 14. So the reason why I'm week 14, I find this interesting because we're actually looking at this, and anyone who was at the Advances meeting in Florida saw that we actually, without me knowing this background Janssen data, which I pulled out of an old slide deck, I didn't realize that people were already starting to think about early drug levels predicting your long-term response. So I want you to get on that theme and remember that it could be that the earlier drug levels actually sets the stage for your entire year, because it would make sense to everybody, right, that if you had a low drug level the first time you got your first maintenance infusion, which is the first 8-week period, how do you expect to get to week 22, 30, 38, 46 with good drug levels if you couldn't even make it to week 14 with good drug level? So this is a kind of a new concept that I'll be pushing, hopefully, and hopefully it will be true, that the idea is if you get even a week 14 drug level and then you dose escalate early, before a patient even progresses on through the whole maintenance strategy, you'll probably get better outcomes at a year because your patient will have good drug levels going into the maintenance period. So they actually looked at this, and they actually showed similarly that patients who had better drug levels, which should say, I'm sorry, greater than 3.5 at week 14, had a higher sustained response effect than patients who had lower drug levels at week 14. So the idea is, and you can make sense, that if after your week 6 infusion, you were kind of not having really metabolizing this drug properly and you had undetectable or low drug levels heading into your first maintenance infusion, you're probably not going to do as well as someone who had really good levels already at their first maintenance infusion. So remember that story in just a second. So this was the presentation we had at Advances in Florida, and we actually showed similarly, we looked at whether or not, one, if a patient had detectable drug levels at week 14, did they have a better outcome at week 54? So it was the same concept that they had done on the Accent trial. And indeed, it looks like that in patients who actually, there was a 70% persistent remission in people who were positive for infliximab levels at week 14 versus those negative, at only a 36% chance of being well 1 year after starting drug. So it looks like levels that you get early actually may predict how you're going to be 1 year after starting drug. So could it be that maybe we should be measuring drug levels early? Yes. Earlier than the time that the patient all of a sudden decides to be symptomatic? Yes. Because the theory is if you get it before the patient becomes symptomatic, and the patient has low levels, you could dose adjust to prevent the patient from flaring. That's the concept. So this is about being one step ahead of the game. And the question is, well, what drug level do I need at week 14? Because no one's told me. Everyone's looked at, if you look at all the data and all the literature, everyone talks about some drug level above 3. If you've seen any therapeutic drug monitoring talk over the last year, everyone uses ELISA-based data and says, old data suggests you should get a level above 3. And a trough level, meaning a drug level at the time of infusion above 3, tends to correlate with good efficacy. It's not really true. And in the new assay that the ANSWER-IFX assay that Prometheus has, it's actually not quite equivalent to the ELISA, and it's actually a little bit higher. And I would even propose, because we looked here, if you took a cut point of 3, you really didn't get a p-value significant difference in outcome at week 54. So 3 is probably too low at week 14. I don't know about any other week, but I'm just telling you, early on, your patients probably need higher drug levels, and 3 is probably not right. We then looked at 5.5, and you did see a difference that people who were greater than 5.5, 85% of patients were in remission versus 48. And look what happens when you use 6.8. 100% of patients go into remission. So the next phase of the data is going to be saying, so what is the best drug level that I need to get early on? Forget 3 that you've been hearing, because at the minute, I'm not really convinced a drug level of 3 is high enough at week 14. Your patient is still early on in their inflammatory cascade, and I think you're going to need higher drug levels early on. And then as the patient gets better, they will need lower drug levels. So that notion of 3, I think, is probably good for someone who's not just started an anti-TNF, infliximab. This is infliximab only. Okay. That's all my fancy. All right. Then they also looked at SONIC, just to remind you that also the story of 3 was a little bit consistent, because in SONIC, which is the adult study where they looked at combination Imuran plus infliximab versus infliximab alone versus Imuran alone, and I just want to remind you that the drug levels in patients who were on combination were higher than in patients who were on monotherapy. Therefore, the suggestion that combination therapy is good, not just because you're getting an added immunomodulator, but you're actually also increasing the drug levels. And if the whole story remains higher drug levels, better outcomes, the theory is that these concomitants do more than just be a sidekick in terms of its immunosuppressive properties. It also increases drug levels. So there's probably a pharmacokinetic profile that is better in patients on combination therapy than monotherapy. So that's probably the story I think we perpetuate most, that the idea that it's important to get concomitant on board because you may get better drug levels, which will result in better outcomes. That's the whole push for why concomitant's important. Now, I'll show you the antibody data, but it's the same. When you have a concomitant, you get less antibodies formed against the anti-TNF therapy, which translates to better drug levels, which translates to better outcomes. So that's the real theme that people are really pushing in terms of the reason for concomitant immunomodulators. Now, the UC story is probably even more critical. If you had to ask me, where is drug level more important, Crohn's or UC? I think it's important in both. But I am absolutely convinced that the reason why people at the beginning were unclear about the role of anti-TNF in UC, and particularly IFX if you go back in time, was the fact we just aren't getting good enough drug levels in people with very pan colitis, a lot of inflammation. These people are literally just pooping out the anti-TNF. And at DDW this year, there will be abstracts where they measured TNF in stool in patients who got anti-TNF therapy. And it shows that patients with higher disease activity have higher stool levels of TNF. So we really are seeing that it's like a sink tank. It just gets sucked in, and with the albumin that's 1.8, your patient's not retaining any protein, right? And out comes the IFX as well in the stool. So it's really important that drug levels with UC, I can tell you, is even more critical. And what we're seeing is, if you look at week 30, the same theme. If you look at all patients in Act 1 and Act 2, so again, the adult indication trial for UC, we can see here that there is a trend. You can see that in patients who had low drug levels, the remission rate was only 14%. If you look at patients kind of in the middle, the second quartile is 25%. But look what happens at week 30 if you actually had patients with better drug levels. Their remission rates went from 25 to close to 60%. So this is where your money is. If you want to get a patient well and you have a UC patient who's not quite doing what you think they should be doing, a lot of the time it's drug level related. and to a point where we're almost rethinking the whole idea of how do we dose ulcerative colitis. So another study similarly showed that patients who had undetectable drug levels, they had actually lower endoscopic improvement compared to those with detectable, and they also had significantly lower remission rates. But this is what's impressive: 55% colectomy rate versus 7 in patients with undetectable drug level at the time of their infusion. So it kind of really speaks to the idea, if you seriously want to use these drugs properly, you need to know the drug level in these patients, especially in someone who's just not quite doing what you want them to do. You need to understand why they're not responding. This, to me, is one of the most fascinating things that was ever presented at DDW. This is the group from Toronto showing their UC, sick, hospitalized UC patient. Now, in most of us, the half-life, those of us who are not severely inflamed and have outpatient IBD, typically the half-life of TNF is about 12 days. The half-life in a hospitalized UC patient is 1 day. Where's it going? In the poop. So the idea is that they have almost 10 to 12 times faster the way that they clear this drug. So how is it possible if we think 5 per kilo in a really sick hospitalized UC patient is going to do anything? So anyways, I'll leave it at that because I don't want to talk too crazy, but I can tell you that my practice has changed completely, and I'm giving 10 per kilo induction in any hospitalized UC patient, period. It's no longer going to try and see and cross my fingers and say, maybe 5 will work. This is a patient who's got low albumin, high CRP. What if patient's other option? Colectomy. So you really have to be serious about managing a sick UC patient. This is the pharmacokinetics. Just to let you know, these are the things that most impact PK: weight, albumin, and anti-drug antibodies. And you should really remember that clearance is probably the most important factor that really relates to whether your patient is going to hold on to their drug or not. And albumin is critical for clearance. If your albumin's low, your patient's clearing that drug faster. We also know that the sicker they are and the higher the CRP, the lower the drug level. So take that into consideration when you're having these sick patients and you're deciding what your dosing strategy is. You really should be adjusting, because assume that a patient who's got really low albumin and high CRP, that drug is going to be in the poop. So the one role for fecal transplant may be in a patient who's got, no, I'm kidding, sick UC patient where you give them back their TNF. Anyways, sorry, Gassan, but that's... So for now, that's what we know about anti-TNF, right? You give it back. So adalimumab is not immune to the same concepts of IFX. So it doesn't matter how we look at it. The reality is such that clinical remission, you fall out of remission faster if you've got low drug levels. Okay, doesn't matter what drug. Certolizumab, any drug, it will be any biologic, to be honest. I don't think I'm just talking to the TNFs. It will be any biologic that has any clearance issues, PK profiles. Golimumab is not immune to this. I'm sure the integrins are not going to be immune to this. The idea is that a patient clears the drug, gets lower drug levels, they will fail faster, right? Good concept. So adalimumab is the same. Just to let you know that all data on adalimumab has been using an ELISA base, just like until AnswerIFX, which is the new immunoassay, that all data in our literature has really been using an ELISA. And we absolutely know that an ELISA is not accurate at all, period. It does not give you an accurate distinction between anti-drug antibodies and drug levels. And you can imagine that, for example, with adalimumab, if you're giving it every 2 weeks and you've got drug levels present, it may be difficult to actually pick up the antibodies in an ELISA base. So newer assays are being developed to be able to distinguish so we can help people use ADA better, to be honest, because it could be that they do actually have adalimumab antibodies and we just need to dose escalate, or perhaps their drug levels are lower than we imagine and we just need to give it weekly, and we can move to that faster. It's exactly what happened with IFX. It's actually helping us manage patients better. I just want to show you the golimumab, which is the next kind of anti-TNF that will probably be coming out for ulcerative colitis, is to show you that it too is not immune to the idea that higher drug levels are associated with better outcomes. So if you look at clinical trials, and if you go and you assume that one fixed dose is going to work for everybody and that everybody's going to get the same drug level, you will absolutely be in the same spot we were with IFX and ADA, where we get a fixed dose approved and there's very little room for movement. So the idea is if we can somehow convince the FDA that there is a lot of there should be flexibility in dosing strategies to allow us to dose escalate based on a drug level early, we can keep patients on drugs and not just be throwing drugs on for 6 weeks and then jumping to the next one. So what I wanted to show you is in clinical remission, when a patient was able to get into the higher quartile, they were able to make a clinical remission of close to 30%. But those patients in the lowest quartile didn't look any different than placebo. So if you're going to give a drug, if you want to give placebo, go ahead. But the idea, this I'm talking to the FDA like you're my audience, but the idea is the goal is to be able to have flexibility in dosing approved, right, so that we can dose escalate early and use drug levels to help us make that argument. We know, as I was saying, what are things that actually impact drug clearance. Just to remind you that albumin is an important predictor of drug clearance, and so is ATIs. And this was shown again in Accent 1. They went back to the data to see what really influences drug clearance. In terms of immunogenicity, just to end with that, to remind you that these drugs are immunogenic. Even the humanized, all human, completely superhuman, they are not the patient's own anti-TNF therapy. Patients are going to get antibodies. It doesn't matter what the basis of the molecule is. So it's very important to remember that immunogenicity is a significant problem for all of our biologics. It's very important to remember, and that's why it's one thing to get a drug level, but it's very important to also know whether or not the drug level is low because the patient has developed antibodies against the drug. So it's important to know both of those things in context. And what I find very interesting, this is our pharmacologists who tell us that, believe it or not, the route of administration, that sub-Q actually is more immunogenic than IV. Different than what we were always thinking for the last decade, I believe, almost so. So I think it's important for us to realize that it could be with new assays, your eyes are going to be wide open. I could tell you at DDW, you will walk away from that going, wow, there are a lot of antibodies against all of the therapies that we use, and it's important that we start using these assays properly because you're going to see that immunogenicity, that sub-Qs are not immune to immunogenicity, truly, and I think it'll help explain a lot of dose escalation. It will help for the pharma to understand why people are stopping their drug. It'll help industry understand why we need to dose escalate. It's a really interesting experience once you start taking off the blindfold and figuring out what's going on. This is old data, ELISA-based, just to remind you what they say in the literature about, for example, in Adalimumab even, the idea that there's only 4% in immunomodulator negative patients. You'll see that that's actually ELISA-based only and not accurate starting July or whenever, May 18th, whenever the presentation will be, you'll see that that data is actually no longer applicable. So it's okay, it's good. It will help us be better at what we do. It's nothing to be running away from. It's important that we're all on the same page, that all of these therapies are immunogenic. Just remember that when you have antibodies, with IFX, you'll get more infusion reactions and you'll get shorter time to needing your next infusion, right? That's what we know. You lose response faster. And the equivalent in adalimumab and certolizumab, you don't get the infusion reaction piece, but you'll just get patients who aren't quite making it to their 2-week mark and they start to flare before, and that's a hint that you need to figure out why the patient is no longer responding. And just to remind you in SONIC, what I told you before, is that at the end of the day, it's important to just remember that in someone who's on combination therapy versus someone who was on monotherapy, you can see that anti-infliximab antibodies were 14% when they were on monotherapy and only 1% on combination. So remind yourself that the role of the concomitant is not just to add risk, which your patients are wondering about, or it's just not to add another 2.5 milligrams per kilo of an immunosuppressant. It's really to decrease antibody formation and increase drug levels, which will increase better outcomes. That's really the story that you and your patients need to start thinking about. AAAs, which is anti-adalimumab formation, was similar, just to the same theme. Patients who have higher anti-adalimumab antibodies, this is an older paper, had lower drug levels and didn't do as well. Same story, same with certolizumab, and I could probably, like, if you named, what about this drug, what about that drug, it would be the exact same, the exact same common theme discussion. So in terms of what we do know is that anti-infliximab levels, as you know in the past, and we've discussed many times, this is just more data, and I have it in your slide deck there to let you know that patients who have a lot of people ask me, what if there's a little bit of antibody? Can I still keep them on drug, and can I still dose escalate? And someone tells me I can overcome antibodies if I just dose escalate them. At the end of the day, I am not 100% convinced that there's such a thing as low level and pushing through antibodies, because at the end of the day, even though short term looks like you may push through, at the end of the day, I think you're just giving people more antigen to form more antibodies, and they're going to stop responding. So you should probably switch once you start getting any antibody level. That's my personal bias, because I've pushed many people to get 0 in return, and I only get infusion reactions. I don't know, maybe it's just me. But there's a report in Europe, and they presented it last year, and they said that there is a group of patients. Now remember, we'll still need better data, but they suggest there's a group of patients you could push through and dose escalate and kind of eliminate those low-level antibodies. I don't know, again, that could be a discussion, and I'd love other people who've tried to push through low levels and see what they get. For me, I just get more antibodies. So that's been my personal experience, but there are reports, and this will come out probably in paper form, because I think I saw the review. So the new assay, just to let you know, the new assay was looking at using a using immunoassay just to see whether or not there is a, researchers looked at whether there is a objective infliximab cutoff using CRP, meaning to see whether or not there's a drug level that best reflects lower CRP. So this was presented at DDW last year, and this is where the story that they looked at as 3 as a cutoff. Again, this was not at week 14. This was random infusions throughout the year. Could have been 4 years on drug. I just want to let you know that I don't want you to be stuck on this 3 quite yet, okay? I think we need a little bit more research and a little bit more massaging of data, but at minimum 3, that's all I can tell you, but I'm saying you really need to start thinking in that 3 to 5 range of getting your patient in that range. There's even a suggestion we may want to go, I'll move forward because I'm running out of time, but there's even a suggestion that we may even want to go up to 7. So somewhere between 3 and 7 is supposedly, and I would tell you closer to 7 for patients just starting on drug, and you could hang out closer to 3 for patients in their maintenance phase. That's kind of where I would keep it. Okay, so what's going to be the future? The future is really going to be about, and the study is currently ongoing, they will take patients sitting in front of you, randomize them to dose escalate based on levels only. I don't care if your patient feels the best they felt in 20 years, but if they have a low drug level, they're going to be escalated to keep a range between 3 and 7. Versus patients, you just go based on their clinical and you dose escalate when they're flaring. Who do you think is going to have a better outcome? I don't know yet the answer, but that's what they're looking at. And they've also started to unveil some of their preliminary data that actually says, you know where drug levels may be helpful? And people have asked me, have you ever de-escalated? Meaning, if a patient has, first of all, I get a lot of patients on 10 per kilo, like every 6, and I get a drug level, it's like 48. And I'm like, you don't need to be on 10 per kilo, and they're perfectly fine. But what about the patients who are on every 8 weeks? Could it be that if you have a really good drug level, can I go to Q10? Can I go to Q12? Sure, just follow your levels and make sure that the patient doesn't become subtherapeutic, because what happens when you become subtherapeutic? You get antibodies. What happens when you get antibodies? You get low drug levels. What happens when you get low drug levels? You fail, right? That's the premise. So how individualizing is going to be, I think this study will be really tremendously helpful in trying to figure out how we individualize. You have a question already? Hold on, I'm ending. Okay, so therapeutic drug monitoring for anti-TNF. Measurable drug levels are associated with improved response outcomes. Anti-infliximab antibodies, and I should add anti-Adalimumab antibodies, are associated with decreased efficacy. I think that drug levels and anti-drug antibodies, this should be a much more generic statement, can help guide treatment decisions, and dose ranges need to be studied during drug development to give us the true PK profiles so we can get better dosing flexibility when drugs are approved through the FDA. I think that's it.